Welcome everyone to Global Tracheostomy Collaborative webinar series focusing on COVID-19. As the chair of the Global Tracheostomy Collaborative Education Committee, I, Vincia Pandian from Johns Hopkins University, am very excited to moderate the session with Dr. Michael Brenner from University of Michigan, who is also the president of Global Tracheostomy Collaborative, and Dr. Amy Freeman Sanderson from University of Technology of Sydney, a member of Global Tracheostomy Collaborative Education Committee as well. The three of us are delighted to have you with us as we discuss some of the best practices and emerging paradigms in telehealth during this COVID-19 era. As all of us as providers or individuals with a tracheostomy or family members taking care of them appreciate the ease of access to care with telehealth without the risk of exposure to viral particles that is quite high with face-to-face consultations during this pandemic. While most patients can communicate with ease over various video conferencing platforms, patients with a tracheostomy might have communication challenges. So we as providers need to be cognizant of those nuances and be prepared to provide the best evidence-based telehealth that's optimal and safe within our time-constrained appointments. So today we have a brilliant group of expert panelists from different parts of the world who will discuss the current landscape of the needs for telehealth and how to optimize telehealth delivery across health settings using varying platform strategies to enhance communication and challenges associated with telehealth. Our webinar today is sponsored by an unrestricted educational grant from Medtronic and Smith Medicals, but none of the speakers are funded by either one of these industry sponsors. As our panelists share their stories, if you have any questions, please type them into the questions section in the control panel, and we will answer your questions towards the end of the session. With that piece of instruction, I will hand over to Michael to introduce our esteemed colleagues who are on our panel today.
Sorry about that. So yeah, it's my absolute pleasure to introduce you to this remarkable panel of individuals. And our first speaker is a good friend of mine who actually I shared training with back about a decade and a half ago. And since he's just had a remarkable career. Dr. Surjani is an associate professor at Stanford. He's also chief of the otolaryngology service at the VA in Palo Alto. He's pioneered work with telemedicine and has actually received millions of dollars in grant funding to build out their telehealth infrastructure well in advance of the pandemic. And so he's going to share some of the really remarkable experiences that they've had doing this. He's also famous for work in retrograde or minimally invasive parotidectomy, as well as having a passion for medical devices. And he just finished a very successful term as chair of our National Academy and the Medical Devices Committee. So he'll be talking to us about telehealth and the VA population. And with that, I'll give the floor to him.
Thank you, Michael. And I want to thank both you and Vincia for inviting me to speak. I appreciate the invitation. So before the COVID-19 pandemic, the US healthcare system was in trouble in terms of increasing populations that is predicted to be increased by 12% by the year 2030, according to the WHO. And furthermore, the section of the population over the age of 65 is supposed to raise by 55% by 2030. That coupled with a shortage of otolaryngologists, which is supposed to be a 22% shortage by 2030, leads to a really big problem. And you can't solve this issue in healthcare in the US by just, training more physicians, because we're still going to have issues with recruitment in the underserved areas of the country. So you really need innovation to get to solve this issue. On the next slide, you'll see that we don't really have to think too hard about this, because telemedicine is the obvious solution. And it's been around since the 1960s, since NASA monitored the health of astronauts in space. There is no set definition for telemedicine, just because the payers, the insurance companies are dealing with modifying the definition. But the widely accepted definition of telemedicine is basically the practice of medicine using technology to provide clinical services at geographically separate sites without the physical presence of the doctor or the patient. And telehealth encompasses a broader area, which includes telementoring between care providers in terms of education and other forms of communication that does not involve the patient. There are various forms of technology. A simple phone call to a patient is a form of telemedicine, but we're going to be focused on video conferencing with patients during my portion of the talk. Email is a form of telemedicine, as well as using any kind of iPhones and other platforms. The clinical services in telemedicine includes professional consultation, diagnosis and treatment, monitoring and coordination, as well as education and mentoring. The delivery type could be in real time, or it could be store and forward. The store and forward is usually for data, like in the form of images and things that are obtained at one point in time and transferred to the doctor to be reviewed at a later time. We'll talk a little bit about the delivery type of remote monitoring, which will be of interest to many of our audience, and mobile health, hopefully, if time allows. On the next slide, I'm going to share with you my contribution to this field of telemedicine. And in 2015 or 2016, our work was published in Head and Neck. I'm a head and neck cancer surgeon, and to take care of cancer patients, it's usually time is of essence. And from the moment we get the referral to the time we treat the cancer is a really important window of time. And historically, our referral would come in, the patient would see us on the first visit 3 weeks later, then they would come back to see the anesthesiologist actually before going to the operating room, and that window of time would be about 49 days. And we started this study with using telemedicine, which allowed us to eliminate the first visit. On the next you'll see that our protocol allowed us to eliminate the first in-person visit, and it was done virtually. So what would happen is the referral would come in, and all the data for the patient, including the biopsy of the cancer and the imaging, would be stored and forwarded to us, and we would validate or review all that information. And my first encounter with the patient 8 days after the referral was basically consenting the patient for the operation they need, and then I would see them in person the day before surgery and finalize the plan and take them to the operating room, and all the follow-up would be virtual. So we eliminated a lot of back and forth and improved the time it took to get the cancer treated. I'm going to share with you one example where this patient is an American Indian from New Mexico. I'm in Palo Alto, and the individual had a very large cancer of the larynx. And historically, we remove the whole larynx and leave them with a tracheal stoma. But for this specific type of cancer, you can do a partial laryngectomy and save the organ. And we were able to successfully do that. And this is the patient about 3 or 4 weeks later, where I'm examining the patient remotely from 1,000 miles away, and a speech and language pathologist is putting the camera down, and you'll see the video here where we're evaluating their reconstructed voice box.
And he's actually moving it pretty well.
Good. I want you to go E, E, E.
You're muted, David.
Sorry, thank you. That was me recording that video that was done 1,000 miles away on my monitor and recording it through several layers of technology. So what I actually saw was a lot better. And you can see this patient avoided a tracheostomy, and we're able to see the endolarynx with with the scope performed 1,000 miles away. So, and you can easily do this with tracheostomies and evaluate, have your tracheostomy evaluated, and the images sent to your doctor elsewhere, so that you don't have to travel far away to get care. You can do it more locally, as long as your hospital has it set up with your provider at the academic institution or wherever your provider is. And now I'm going to hand it over to our other panelists. There's a lot of great talks.
Great. Well, thanks so much for that introduction, David. Just kicking things off, I think that relatively few of us would have realized that the history of telemedicine is as long as rich, dating back to NASA and even well before. And what David has really helped me appreciate is that telemedicine is, it's not just a flash in the pan, even though we saw it spike dramatically in its use during the pandemic. It's really changes that are here to stay, and I think are going to revolutionize the practice of medicine. So our next speaker, Carolyn Chow, is a respiratory physiotherapist at Austin Health in Melbourne, Australia. She actually wears a couple of hats. She works both as a member of TRAMS, which is a tracheostomy review and management service, which those of you that watch these webinars regularly will be well acquainted with, is the pinnacle of tracheostomy care. She also serves on the team of the Victorian Respiratory Support Service. She does a lot of work with chronic ventilation, weaning for prolonged ventilated patients, and management of patients with neuromuscular disorders. She brings a wealth of expertise spanning easily a decade and a half, probably more. And she's going to talk to us about the pros and cons of telehealth with some perspectives on rural health and telementoring. Take it away, Carolyn.
Thanks so much, Michael and Vincia. It's great to be here today. So at Austin Health, we're a tertiary hospital in Melbourne. We have two specialist services, as Michael mentioned, one of them being TRAMS, who looks after patients in the acute setting as well as in the community setting for patients with long-term tracheostomy. And our other service is the Victorian Respiratory Support Service. So that's a statewide home mechanical ventilation service. And we manage patients who require chronic ventilation, either in the form of chronic NIV or long-term ventilation via tracheostomy. And so the VRSS also manages a statewide ventilation weaning unit, where we wean difficult to wean patients in a setting outside of an intensive care unit. Another statewide service I should also mention at Austin is the Victorian Spinal Cord Injury Service. So the combination of these services being co-located at the Austin means we've got a critical mass of acute tracheostomy patients, but also a lot of patients with long-term tracheostomies with or without a ventilator, living in often quite remote areas. Anyone who hasn't travelled to Victoria, we're the southernmost state in mainland Australia, so that little red dot in the map, which size-wise is roughly about the size of the UK. And currently with the COVID pandemic, we're also in the unfortunate position of being the worst affected state, and Victoria accounts for almost 75% of all COVID cases in Australia. So our journey with telehealth began well before COVID, almost a similar time to Dr. Sajani. So back in 2016, and I need to thank my colleague for his conference poster, which is shown here. And being a service that had clients that were spread all over the state, we received a grant to establish and scale up telehealth services for the multidisciplinary team. And that was made up of respiratory physicians, an outreach nursing team, and respiratory physios. And over a 12-month period, this involved testing a new video conferencing platform, looking at ways of troubleshooting, collating data and feedback from our patients, and essentially detailing a sustainable service model. So some of the main findings were significant savings in travel time for the patients, so over 840 hours and over 62,000 kilometres of travel time which was saved, which is conservatively estimated to reduce costs for patients of around $35,000. There was a significant reduction in the outpatient waiting list, and happily we were also able to re-engage some high-risk clients who hadn't attended in-person clinical reviews with a physician in over 12 months. And these were the patients who had cancelled or failed to attend multiple clinical appointments. So many of the highlights and downsides of telehealth that we encountered are a lot of the things that you will see in published research on telehealth. Clients tend to rate telehealth experience favourably. Telehealth does enable multidisciplinary consultations rather than the traditional medical model of outpatient clinics. Compared to phone calls, telehealth platform was an additional tool to help troubleshoot problems. So being able to visualise the patient, equipment, tracheostomy stomas, we could provide more accurate or more detailed advice to the client. And we're also able to effectively use the platform for training and supervising regional hospital staff to try to avoid a transfer to Melbourne. But with all the pluses, there were downsides too. So the usual technological issues, mostly to do with a new platform, internet bandwidth, and patients who perhaps aren't as tech savvy. With telehealth, there's no ability to physically examine your patient, so there are potentially aspects of an assessment that can be missed. A lot of the efficiencies tended to be experienced by patients rather than clinicians, and there was a higher administrative burden compared to outpatient clinics. And interesting at the time, as to be expected with anything new, there was a little bit of resistance to change, but I think this year experience has taught us left with little choice, we're all pretty adaptable. And since then, telehealth has continued to grow, and the telehealth platform that we tested for the project Health Direct is still the one that we use today, with some improvements for the end user, like easier access and improved waiting room, which did reduce some of that administrative burden. Medicare funding has certainly made it easier for billing, particularly this year with COVID. And so many other departments have then modelled their clinics based on our model, and they've been used in tele-rehab clinical trials. So particularly during the COVID pandemic, though, we've had a few additional experiences that we thought were well worth sharing. And that was that telehealth was certainly able to expedite clinical review and allow us to stay in touch with our patients despite quite a very strict lockdown and curfew here in Melbourne. With the second wave, we had a major COVID outbreak in the aged care sector. And so we've used telehealth to review our trachea patients in residential care facilities and also to review patients on the acute COVID wards, thus reducing staff exposure. With social distancing, all of our face-to-face education was ceased, so we had to pivot our approach. And this was presented in the last GTC webinar, which is available to view. Even with all the restrictions and social distancing, though, we've found communication with care partners such as care agencies and community providers has actually been easier, and it's more streamlined because everybody is online nowadays. But we've also encountered a few additional risks. As mentioned before, physical examination is limited. It was particularly difficult with our dysarthric and our anarthric patients. We've had many patients who have been afraid of coming to hospital because they're fearful of contracting COVID at the hospital. So we've had instances with patients calling and requesting telehealth appointments, but when contacted by a clinician, it's very clear that they were actually quite sick and they actually needed to present to an emergency department. So I think there is that risk of people delaying seeking help, thinking that telehealth was an alternative to coming into hospital. But on the other hand, we also had a group of patients who really didn't want telehealth and who still wanted face-to-face consultations because they felt disengaged from their healthcare providers. And a good example I had was a patient who was diagnosed with motor neuron disease or ALS in February, just before the pandemic hit us. And then in July, when I saw him in person, he said I was the first health professional that he had seen since his diagnosis. And he was just so grateful to be able to attend an in-person appointment and that he just wasn't talking to a screen. So while telehealth certainly been useful, particularly during the pandemic, we do need to remember patient-centred care and how we tailor our care needs to be balanced with staff safety. And for some patients, telehealth can be a true replacement for in-person consultations. But I think for others, we should also then think of telehealth just as an adjunct to our management rather than a true replacement. And while telehealth has been used really successfully in many outpatient settings, it really wasn't until COVID that we really started thinking about the use in an inpatient setting. And with the strict lockdown for hospital inpatients, that meant no visitors. For our students, it meant that most clinical placements were cancelled. And so these video on wheels devices have been particularly useful on ward rounds where we had restrictions on the number of clinicians at the bedside. and we could still then consult with their carers and family members and enable them to ask questions. And for our students, we've been using these devices to conduct virtual clinical placements. So the students are still able to conduct patient assessments over telehealth, supervise rehab, conduct patient education sessions. But it's still a bit of a novelty seeing clinicians and patients talking and wheeling these devices as they walk around a ward. And finally, as a way of connecting with our tracheostomy community, we usually run twice a year these patient and family forums. Usually they're held on site. We have a lunch, we have key speakers and group activities. This year we had to run our first online forum, but we're still able to connect using technology and to be able to hear some of our inspiring patients talk about how they've been able to manage to stay connected through the pandemic. Thank you.
That was absolutely wonderful, Carolyn. Thanks for that really outstanding overview. And it was such a delight taking part in that symphony of stories. There's so many outstanding things that all of you do in Australia, and we all look up to you for the advice and work that you do in that area. I had to chuckle as you listed in your downside column about one of the disadvantages was effectively that it's really great for patients, but it's not necessarily great for doctors. It sort of speaks to the fact that we, particularly, I think those of us who are physicians are a little bit cantankerous and tend to be a little bit staff and physician centered rather than patient centered. And what the COVID-19 pandemic has really taught us is what the capabilities are of telemedicine. And it's forced us to learn how to do some of the things that we never bothered to become proficient with. So with that, we're going to transition to Professor Jessica Peck, who is truly remarkable. Like when I first read her biography, I thought I was going to find somebody 100 years old, but as you can see, she's clearly much more youthful. And you can judge someone largely by who they train and what they bring out in them. So this is also an introduction of Laura Ann Moreno, who she'll introduce some of the work of. But to just tell you a little bit about Professor Peck, so she is a superb expert pediatric clinician. She has a number of leadership roles. She's president of the National Association of Pediatric Nurse Practitioners. She's a professor of nursing at Baylor. She studies work, including the impacts of social media on teens. She also, and I appreciate this especially in the midst of a pandemic, she's the mother of 4 children and particularly values supporting physical, emotional, psychosocial, and spiritual wellness. Their topic is going to cover a variety of areas, including preparation for decannulation, so the aspects of and access to care of immigrants between borders. So I'll give it back to you now, Jessica. Thanks for joining us.
Thank you so much, Michael. Thank you for that kind introduction. I'm sure my mother somewhere is beaming and proud, but thank you for that. I appreciate it. And thank you for the invitation to be a part of this important work. As you said, I'm a pediatric nurse practitioner with a Doctor of Nursing practice degree. And nurse practitioners are registered nurses with advanced clinical training for preventive care, as well as management of acute and chronic illness with appropriate diagnosing and prescribing. So I'm a professor and nursing faculty, and I've been helping to start these DNP programs in Texas. And DNPs are really experts in translational research. We don't generate new research, but we rapidly translate existing research to individual community or population needs to improve outcomes. So we conduct evidence-based or quality improvement projects designed for maximum community impact. Some of those examples include improving self-management of diabetes or helping people quit smoking, decreasing childhood obesity, and in this case, telemedicine for pediatric patients who have tracheostomy tubes. So telemedicine obviously is very effective, but it is not necessarily available. As most of you probably know, Texas is a really big state, and this project came from the Island University, or Texas A&M University in Corpus Christi, where we placed the first DNP program south of Houston. And that was in the middle of a 400-mile area previously with no doctoral education opportunity and very limited access to healthcare. So in working with my student, Laura, who I'm about to introduce, she came to me, and her problem that she identified was she was seeing increasing complications in pediatric patients with newly placed tracheostomy tubes. So she set out to create a protocol to improve the discharge and post-hospital care with the use of telehealth. And now this was all pre-COVID-19 pandemic. So this project was published in the Journal of Pediatric Healthcare, and she is here to tell you about it, and I'm going to tell you about her. So Dr. Laura Moreno graduated from Texas A&M University Corpus Christi with her master's degree as a family nurse practitioner in 2013, and then she came back to get her Doctor of Nursing Practice degree in 2018. She continues a 22-year commitment to Driscoll Children's Hospital and upholds their mission to provide quality health care and improve the lives of vulnerable pediatric patient populations. She is well respected in her community and has gotten lots of awards and has been a leader in implementing telehealth. And so, Laura, I'm so excited for you to tell everybody about what you did.
So good afternoon, everybody, and thank you for the invitation to speak today. So again, my name is Laura Moreno, and I am a family nurse practitioner with the Ear, Nose, and Throat Service at Driscoll Children's Hospital in Corpus Christi, Texas. So I have worked alongside an ENT physician for the past 7 years. So we care for not only inpatient, but outpatient pediatric patients. So yes, as Dr. Peck mentioned, my DNP project identified a major problem in my clinical practice setting, particularly among patients with a newly placed tracheostomy tube. So these patients came to their initial follow-up appointment 2 to 3 months after their hospital discharge as part of their standard protocol at that time. So caregivers often reported being seen in the emergency room at least once, or having been rehospitalized within a month after hospital discharge. And I thought this was, pretty outrageous. Many of these caregivers and even the home health nurses reported being really anxious or just lacked confidence about, assuming total care for their complex child. So they often had many questions at their first appointment about just routine tracheostomy care and just, things that they had basically been taught in their hospitalization. It almost seemed like they had forgotten everything that they had been taught. So Driscoll Children's Hospital is the leading pediatric center in South Texas. So providing care to, patients throughout Corpus Christi and the surrounding areas, as well as, the southern cities of Texas, Laredo, the Rio Grande Valley, and Brownsville. So access to care is challenging for many of our families because of immigration, finances, transportation, and employment. So we have to remember that many tracheostomy patients have had an extended hospitalization, and caregivers have been away from home, their families, and work for a long time. So immigration is a major barrier for our caregivers in terms of seeking follow-up care for their medically complex child. So unfortunately, there are 8 border checkpoints between Corpus Christi and the southern towns as shown here on the Texas map. So many families don't even want to risk traveling to Corpus Christi. They fear deportation particularly, and they just simply choose not to come to their follow-up visits. And unfortunately, the patient goes without unnecessary and specialized medical care. So this places them at increased risk of complications and ultimately preventable situations. So patients met the study criteria for my project if they were between the ages of 2 months and 18 years of age with a newly placed tracheostomy tube and lived outside of the Corpus Christi area. The setting for the study was at Driscoll Children's Hospital, and the telehealth visits only took place at either satellite clinics at our McAllen or Laredo facilities. The staff here were already telehealth trained, and all of the telehealth equipment was readily available there. So I initiated a process in which patients had a follow-up appointment scheduled before they even left the hospital. So the first visit was the telehealth visit at 2 weeks post-hospital discharge, and the second visit was actually in person 4 weeks after hospital discharge. So I used measurement tools to evaluate caregiver knowledge about providing routine tracheostomy care, including suctioning and changing the tracheostomy tube, and just how well they felt prepared for home care. These measurement tools were implemented and scored either before discharge and at each patient-provider encounter. So the results showed an increase in all my survey scores. So caregivers who had the telehealth visit demonstrated better tracheostomy care and just overall confidence. There were no tracheostomy associated complications, no ER visits, no rehospitalizations. They were very appreciative and satisfied with their overall telehealth experience. So ironically, during one of my visits, one of the patients had an accidental decannulation. So I was able to witness how the mother and the home health nurse worked calmly and together to reinsert the tracheostomy tube. So they needed little guidance from me, and of course I gave them a lot of positive reinforcement. Now this situation, I believe, could have easily turned into a ER visit or hospital readmission had it occurred in another setting. So initially, many thought telehealth would not work for our ENT patients. However, it really has proven to be successful and effective. It has also been very convenient for patients who are complex, who are difficult to transport, and who rely on various medical equipment. The current COVID pandemic has allowed telehealth to become a primary method of providing quality care, not only to tracheostomy patients, but all our ENT patients. Before COVID, only 2 other services at Driscoll were incorporating telehealth into their routine practice, and now every specialty across the board at Driscoll is now offering telehealth.
All right, well, thank you so much for that. That's really a remarkable body of work for someone, especially, you know, as a doctoral thesis. I think that now, Dawood, you are going to impart with us some wisdom. Is that correct?
I'm sorry. I think Claire was going to go next.
Okay, well, why don't I then introduce Claire? Sorry about that. So Dr. Claire Burns, you can wave your hand, is a advanced speech pathologist at Royal Brisbane and Women's Hospital, Metro North HHS Clinical Research Fellow, and an honorary senior lecturer at the University of Queensland, excuse me. She has over 20 years of clinical experience, and she's been involved in a number of important articles. She co-developed the Speech Pathology Australia's telepractice position statement, and her telepractice research that focuses on developing, evaluating, and implementing tools of care and speech pathology. She also works in multidisciplinary care and broader allied health services, and she's going to give us some insights regarding her breadth of experience, as well as particularly focusing on preparation for decannulation.
Thanks very much, Michael, and thanks to you and Vincia for the opportunity to present our services today. As Michael said, I live in Queensland, which is just north of Victoria, where Caroline is based. And Queensland Health is a very large public health service. Queensland itself has 5 million people that Queensland Health supports, but over 50% of these actually live outside the capital city of Brisbane, highlighted in the star there on the map. So specialist services are provided by quaternary and larger regional hospitals. However, due to our geographical diversity, we have some service challenges. So things like coordinating care across sites, patients needing to travel to metro centres for intervention, which then results in service costs and burden for family and the patient. And there's also issues with workforce training as well. So our government has acknowledged this, and for many years has provided a funded telehealth network where before COVID there were over 2,000 telehealth systems, over 200 facilities, and through this we've been very active in telehealth research and services for more than 6 years here at the Royal Brisbane Hospital alone. But obviously with COVID-19 there's been an ongoing expansion of these services through our health district. So here at the Royal Brisbane Hospital, we have an inpatient tracheostomy management service, and Sonia Baker is our speech pathologist on that team and is involved in these services. And the TMS and wider critical care team conduct two telehealth service models to support tracheostomy management. And the first is the coordination of specialist care and staff mentoring, where the ICU team conducts ward rounds with regional hospitals to support patient care and also provide service training. And the TMS also meets twice weekly with the trachea patients and the treating team from our rehabilitation facility, which is actually off-site, where the patient, so they actually provide services to that team with the patient to look at the process of cuff deflation through to decannulation. When patients with tracheostomies are transferred to other facilities, then handover is provided via telehealth too, and obviously ad hoc support and specialist care is assisted through tele too. The second model that we have is our slow to wean decannulation support model, where our TMS supports complex patients with low GCS who are residing at a slow stream rehab unit in the metropolitan area here in Brisbane. And what they do is they support the patient through that coordination process of weaning from cuff deflation to decannulation. These are patients who aren't known to the TMS team per se at the Royal Brisbane, but as part of that decannulation process, the team gets involved to provide specialist care. They consult with the team at the facility, plus also the patients and the patient's family. And they plan the decannulation pathway, but then just before the patient comes into the hospital for admission for decannulation, they also meet with the team and the patient and family again, just to look at the process and also plan any contingencies that might need to happen if things don't go to plan. So it's really focusing on that patient-centred care where everyone is involved in the discussion and the decision-making process. In speech pathology, we have been very lucky to have the expertise of Professor Liz Ward and also the UQ team, and together have collaborated to be able to develop a streamlined telepractice service for our patients. And that service is both providing direct care to the patient and also providing specialist consultations. And we have supported tracheostomy patients within this model. We provide a range of clinical services through telehealth. We provide clinical handover to clinicians at other sites when patients are transferred. And importantly, we meet with the patients before they come down to the hospital here to triage what their needs are, so that when they come to the Royal, we're able to actually coordinate that care in a streamlined manner during their stay. In terms of our clinical services for speech pathology directly, we have validated a model of care for clinical swallowing examinations via telehealth, which includes an oromotor examination, and we've adapted that for our tracheostomy population. So we've been able to do cuff deflation trials. We've reviewed instrumental assessments such as FEAS and video fluoroscopy via telehealth with clinicians to plan rehabilitation and then also to directly provide therapy. We've supported communication through speaking valve management. And like Caroline was talking about before, we've really tried to engage the whole MDT team by getting our ENT down to have a look at a stoma that we're concerned about, or the tracheostomy management nurse. And we've used both online video conferencing and also store and forward to be able to provide these supports. And what we have found is that there's a higher rate of appropriate referrals to our MDT team through using telehealth rather than our usual care model, which would be email and phone contact, or waiting for the patient to come down to Brisbane to see us here face to face. In terms of looking at our RBWH speech pathology model for tele, we've been able to look at a number of different factors that have really provided some success in relation to our model of care. In particular, we've used multi-point calls to be able to coordinate patient care, so linking in all of the key stakeholders in the consultation, whether that be the specialist team at the Royal, the patient site, looking at carers or family members that may not be able to come to the consultation. We've been able to link them in so that everyone can share the consultation and the decision-making process. We've used mobile technology to optimise our audio-visual requirements. Some of our regional sites have a medical camera system that provides really fine detail of the stoma, for example. You can see that on the right-hand side of the slide there. And we've also used mobile web cameras, so we're able to actually look very closely into the mouth or the stoma. And if the camera is not mobile, we've coupled in other devices, such as a camera from a smartphone, to be able to get that view. We've used synchronous, so real-time video conferencing, and also store and forward, like David was saying, in terms of those still images. particularly in situations where maybe the bandwidth isn't good enough to be able to see it really clearly, or the images really clearly, or in other situations where we're wanting to record that to then show the images to a colleague later on. And we've optimised the VC platform using the text box, for example, in Teams to be able to support patients who may have difficulty communicating verbally. In the slide backwards, there's just a few other points that we've used the clinical procedures, and we've considered how we can adapt our clinical procedures in an in-person appointment into a face-to-face model. So we've adapted the patient's position for a swallowing assessment. For example, you can see there on the slide, she's turned side on. We've used clear cups and spoons so that you can see the fluid going into her mouth. And the white piece of tape allows the telepractice speech pathologist to be able to see laryngeal excursion, which is a key part of our swallowing exam. We've also monitored the patient's saturations during the assessment, as you would do in an in-person appointment, and just getting their support person or their assistant to be able to tell us that data across the platform. We know that telehealth is new for patients and also for clinicians, and for that reason we've supported our patients by providing them with assistance around tech setup and even giving them resources that they might need for their telehealth appointment. And importantly, telehealth is different for the clinician as well. We do need to provide some training, and there's a different set of skills that's required. So we've really invested in that by developing e-learning programs that we've shared online with clinicians and conducting workshops and online training as well. So as part of our research model, because we've developed all of our tele models within a research framework, we've also been able to evaluate these quite comprehensively, and we've been able to prove that there's enhanced patient outcomes, service efficiencies, we've got cost benefits for the patient and the health service, great satisfaction, but also workforce training opportunities too. And we continue to monitor these as part of our usual care evaluation. And as the other speakers have said today, you know, there are challenges with providing telehealth, and it is really important to consider telehealth as an individual decision for that particular patient, for that particular session. Here at the Royal Brisbane, we've acknowledged that, and we actually provide an integrated service as part of our usual care, knowing that not every clinical appointment can be provided via telehealth, or maybe the patient might have a preference to come in for a face-to-face appointment or a telepractice appointment. So for that reason, we use a combination of in-person, phone, and also telehealth. And we're hoping that through that model, we will be able to continue and sustain our clinical service. So I've just provided some references if you're interested in learning a little bit more about our service or the models that we've used. And in particular, Speech Pathology Australia has some fantastic telepractice resources if you're wanting to look at sort of practical videos, and also resources that we can share. Thank you very much.
Thanks for that wonderful presentation, Claire. That was really illuminating for all of us. And I think you're going to give David with his multi-million-dollar setup a run for his money on some of the sophisticated endoscopy work that you're doing. I mean, there's actually so much commonality between what we do across our different specialties, and the talent and knowledge that you bring to bear on is really outstanding. So now we're going to talk to your counterpart on this session, also a speech-language pathologist. We're going to move from Australia to the NHS to introduce Rebecca Davies. So Rebecca is a speech-language therapist who has specialized in health informatics. She's actually assumed a number of leadership roles. These have variously included being a co-author on the RCSLT telehealth guidelines, which I believe is the Royal College of Speech-Language Therapy. She's collaborated with Microsoft and other major industry players to develop important technologies and deploy them. She's done work with online decision-making tools, and she was recently commissioned to write a guide to telehealth for clinicians. So she's going to kind of look at the real high-level, systems-level orchestrations, and to give us some perspective on online dysphagia assessment. So we're delighted to have you here, Rebecca, and we'll let you be our closing speaker with David as an anchor person. Please forgive the misstep in the transitions earlier.
Thank you so much, and thank you for inviting me. It's a real privilege to be able to share our story from a little bit of the UK with everybody here. And just to give a bit of a brief history about how I came to be where I am in terms of my journey with telehealth. I came from a paediatric background, over 10 years working with paediatrics, and that's where I first came across telehealth, very different in mainstream schools as part of my independent practice. And when I came to work in the adult sector, I knew straight away it was something that I wanted to build into the service that we already had, and went about finding how to do that pretty much straight away into the area I worked, which was voice and head and neck cancer. And being eager to introduce this service, I was very much aware that across the world and the global market, this was happening really well. And in the UK, we were only using it in very small pockets in remote settings, rather than using it more broadly in acute settings. And I was keen to look at how that could be done. I was in a really strong position because at the time Microsoft Teams was just being released and the global health lead was visiting the UK. And because I'd raised this question about how we could get telehealth into our service, they pushed this guy in front of me and said, "Can you help her? She wants to do video sessions." There were a lot of misgivings. A lot of it was around information governance and security and how was this possibly going to work. It was a lot about the fear of the unknown. When we got Microsoft on board, they were fascinated because it hadn't been used as a clinical tool at that point. And they were very much excited about how they could support and look towards using this within their remit of supporting healthcare. So having been introduced to Microsoft Teams in that way, that is what became the pilot platform for the speech and language therapy service to use. And it's different using it in a healthcare environment because it had its limitations, because we couldn't send SMS links, we could only send email. And the pilot project was quite small and select with a number of voice patients. And it literally was signed off 2 months before COVID hit. So although that was quite scary, it put us in a strong position. And that's why I ended up in the clinical informatics department, because I'd led on the project in speech and language therapy, and we knew we needed to upscale rapidly to get to 40 plus services across the trust. So it was very much about using the learning from speech and language therapy and deploying that as rapidly and quickly as I could into all these other services on the fly, really. So having discovered that this was what I really wanted to do, I was keen to progress this. And although it was daunting, I just went with it. And the journey has been interesting and hard, and it's still been. And it's allowed for collaboration with not only the internal teams and the internal stakeholders, but those further afield external stakeholders. So the wider NHS, in terms of it's broken down in the UK into NHS Digital, NHSX is a new collaboration between the Department of Health and Social Care and the digital and improvement arms of the NHS. So there's little pockets of people working together towards the longer term aim of the NHS, which is to be digital by default. Part of a 5-year plan initially, I think we've already achieved probably 75% of that 5-year plan already in a very short space of time. So looking at the initial hurdles that we faced, very much the barriers were about the hardware themselves and getting people engaged. We'd got limited tablets, we'd got laptops that didn't have webcams and microphones, and then we were asking people to do video consultations but not the right equipment. The other factors that came in was the platform we were going to use. Could we upscale Teams to do what we needed in such a short space of time? And everything linked back to the GDPR and the security. We were fortunate in that the NHS developed a partnership recently with Microsoft, which has given us that level of security in terms of using this for a healthcare environment. And there are some organisations that are still quite hesitant because it's seen as a corporate tool, but we've used it really successfully clinically, and we're keen to share that learning. And Microsoft are working with us to develop a healthcare-driven environment as a plugin to go on. So we're the pilot site in Rotherham for that, which is really exciting. I'm really privileged to be part of that. So with every business change piece of work, there's going to be differences in how people come on board with things and the journey that they have. So the previous slide shows, that journey people have from being the early adopters and the innovators to the ones that are left behind or fall down the chasm because they're not sure where they stand with things. And then they realise that they are going to have to come along on that journey with you. And it's looking at how you support those different groups of people so that everybody works towards that end goal. And part of that has been finding that right level of reassurance for people, which has come from working with the right platform. So Microsoft Teams has worked brilliantly in lots of services, but as the next slide shows, we had to look at different platforms to fit different services, because we realised that not all patients could access email. They could only access an SMS via a smartphone. Additional layers of security and privacy, so having a blur the background feature, which was only available in some platforms. But I developed a toolkit of the platforms that we now use across the trust at the moment, so that clinicians can choose what works for their patients to give them the reassurance, but to add the additional features, so we can share images and they can upload documents, we can do screen sharing and do online assessments. So it's really adapting the digital tools we've got to make them work for the orchestra that actually could turn into a cacophony, but we want it to be a symphony and have everybody working together. So this is very much part of setting the expectations and boundaries for patients from clinicians. A lot of this was built into the consent process, so this was very new to us, and we had to look at ways that we could extend what we were already doing into these new ways of working. So it was very much stepping back and saying, what do we do now? How can we make this a digital process? And the consent has become part of the expectations, where that if you were on the end of a screen or the other side of a screen, you would be there, at any time of the day. So it was ensuring that patients were aware that yes, they could send you a message and they could drop you an email or a Teams message, but you would reply in the same times. It wasn't that you were just at their beck and call suddenly. So it's finding ways around working in terms of that has been one of the greatest challenges, because clinicians really didn't know what to do sometimes when they said a patient's emailed me at 2 o'clock in the morning, but they thought I was going to respond. Wouldn't have done normally, and stepping back and looking at ways we can really support staff to ensure that the service that they're given is equitable, but it's safe and within all the other existing protocols. For us as a service, as a speech therapist, our core work has been dysphagia, and none more so than during the COVID. And so this has seen a huge rise in admissions around tracheostomies. We were receiving initially 2 to 3 patients a week, and that escalated very quickly. We're a very small trust, and we were having between 10 and 12 patients a week. So it was a massive rise for us. It wasn't a case sometimes that the speech and language therapist could always get to see that patient before they were discharged. So they were going home with a trachea in situ, and we needed to find a quick, safe way of getting them supported remotely. And telehealth has allowed us to do that. It's allowed us to do the remote assessments. It's allowed us to do the voice assessments, where patients that have been intubated have then had a vocal palsy or other voice issues that has impacted. And it's allowed us to make these situations remotely possible that were considered completely impossible before. The adaptation that we're faced is looking at what we do now, and we've translated a lot of our existing assessments, all the scales. We've used Microsoft Forms an awful lot in terms of collating data. It's allowed us to be more efficient because they can be sent out to patients before to fill in subjective scales in terms of well-being, mental health, so that you're not having to do that session and take up additional time. You have that information before, and that's been really beneficial. We're working across multiple platforms and continuing to develop the MS Teams setting. We've taken into account the risk. So nationally, the way in which patients have gauged has changed a lot, and has led to an organisational concern across our trust and across the NHS that remote working isn't without risk, and how do we combat that? And for every different service, that looks slightly different, and multiple factors are going to influence that, around privacy, the GDPR, even the quality and the clarity of what you're seeing on screen. Is it safe enough for you to diagnose a patient? And that has, as Michael mentioned, that's given rise to the work that I've been doing with RCSLT around the online decision-making tool, and making sure that there are really clear guidelines for our profession in terms of what is safe to do with their patients and how are the best ways to do that. And Claire and her colleagues' work have informed a lot of that for us in the UK, which has been amazing. So looking to the future, and how do we maintain what we've got into place in a very short space of time? We've joked quite a lot in our department that in the time that it took me to roll out video consultations to 40 services, we were still waiting for a notice board to be put up. And that's how the NHS usually operates. We've managed to do years worth of work into a very short space of time. And we want to maintain that and keep continuing to innovate what we're doing in our services. So we're using that knowledge that we know worked in speech and language therapy to keep continuing to develop best practice across the trust. And that means going remote support for our existing patients that we knew the services were already working with, and continuing to collaborate with the new services that are now on board and taking that forward. As a trust, 25% of all our outpatients appointments by the end of 2022 are expected to be via telehealth, with 75% by the end of 2025. So we've got a massive way to go. My contract ends in 2022, so I've got a huge task ahead of me. But this isn't going to go away. As this is part of our practice, it's here to stay, and we need to find ways of facilitating that and making it the best it can be for everybody, and really making this a digital by default world.
Okay.
Thank you for orchestrating those, so I'll hand it over to Davud now.
Can we skip to the conclusion slide? So in summary, I'm really honored to be included in a panel of very, very accomplished individuals who really contributed to the field of telemedicine. And I get a sense that the people outside the US are a little bit ahead of the game in terms of providing telemedicine care to their patients. It's really the right thing to do. And the last slide was really a slide that some of the barriers in the US were, you know, some of the laws and reimbursement issues and practicing across state lines, which have all really been put on hold because of COVID-19. And again, I'm honored to see how much has been accomplished. And to summarize, I think everybody's touched on the point that telemedicine can be used to remotely evaluate patients and formulate treatment plans. I particularly liked Jessica and Laura's access to care, access to subspecialty care in Texas, because those remote areas, I mean, I have the same issue here with dealing with veterans who are in remote areas and trying to provide them the proper subspecialty care is really important. And telemedicine allows us to really use our resources efficiently to reach out and help patients. We've all really touched up on wait times for the patients are improved with telemedicine. And there's no question that there's a cost savings in the system, in the healthcare system. There's a huge cost to start the system, but after it's started, you're reducing travel costs, you're making it more efficient with your resources in terms of your providers' time and things like that. Not to mention that the patient satisfactions are really high, and there's overall it's really a plus, and the pandemic has helped move things forward. And I'm really just delighted to see what you all are doing with providing care for your tracheostomy patients and using telemedicine. You know, in the future, the big deal is going to be using wearables mixed with artificial intelligence to compute all the large data obtained from wearables. In particular, I think there's ventilator remote monitoring systems that are made by many companies where the ventilator itself can link to a electronic medical system where your doctor gets real-time data, and it reduces the number of ER visits and the number of in-hospital visits. and it allows your doctor to really look at a large set of data to help mainstream the delivery and personalize the care to the individual. You know, this technology can improve early detection of cancers and disease processes. It improves outcomes and it improves overall quality of care. And it's here to stay. And I think COVID actually helped accelerate that process that's been going on for at least a decade. And I hope we have another one of these panels and add to it. It's really been amazing to be part of this. Thank you.
Thanks so much, Dawood. That's really phenomenal. And all the speakers, as well as our participants, have stayed with us through the hour, are all collectively building the future. Really, I think that telemedicine is you know, the future is here. So we're going to have Amy Freeman now take charge and walk us through some of the questions.
Thank you so much to all the panelists and speakers for such an enlightening hour. It's just been a privilege to even listen to all of you. I feel very selfish because I feel I've got the floor for all the questions. Just in regards to moving forward, I guess really your key gems of information in regards to optimizing our patient interaction with telehealth and getting the best view and best equipment. I'm just wondering if you could just, if I could have someone come forward to say what type of views or education should we be giving to patients to optimizing their interaction with telehealth? So, I mean, maybe perhaps Claire, with your protocols, you mentioned about clear cups, different views. I mean, what would be some quick advice that we could give to patients around optimal setup?
Yeah, I think it's really important to set the patient up appropriately so it's a good experience for them, but also you're getting the clinical information that you need. So I think we do test quick, connect with patients and do a screen beforehand to make sure that their technology is available and they're set up for that. You need to also think about what devices they have. If they have a laptop, desktop versus an iPhone, that's often better because you're able to actually get them to sit and be positioned better in front of the screen. So looking at their tech and how it's set up so that you're really getting the views that you want. We also have developed resources that we send out to the patients, so quick reference guides, if you like, of what the actual clinical tasks are that you're wanting them to do, so that they're then prepared with the setup of their equipment. They know what the tasks are, or at least know the process that you're going to go through with them, and if there's any resources that they need. So if they need to have a cup of cordial for a swallowing assessment, or if they need a torch available to look inside their mouth, that they've got all of that ready. And similarly, if they have assistant or a carer with them too, you need to be able to provide that information to them because they're the ones who are going to help you get the information that you need for your assessment. So equally, it's important to provide some information and training to that person as well.
And that's been what all of our speakers echoed, just even a small pilot to initially just establish and test the system in terms of what you need and tailor it to that individual, so where they're maximising their benefit, the success for both the patient and also the staff doing their telehealth consult. Just in regards to carers, I suppose moving on to Laura and Jessica, we know with managing, I mean, it's across pediatrics and adults, but managing patients come with multiple family members, different languages spoken as well. So how has your model opened that up to allow more than maybe the primary carer to be available or different languages being spoken?
So yeah, so a large population of our patients is Spanish speaking. So we have translators available. Fortunately, I speak Spanish, so it's not really an issue for me, but we do have translator services. And so in terms of, you know, before the telehealth, you know, it was somebody else bringing the child to their appointment. So not the caregiver. So somebody who did not know really what was going on with the patient, not somebody who typically took care of the patient on a daily basis. So that added some difficulty. But with telehealth, that's really changed how we're able to provide care for them. And I could talk to the parent directly. I could see them. I could ask them to demonstrate something for me, like a routine procedure. So yeah, I think that telehealth has made a huge difference for our patients.
And really improving the access and the information to everyone around that person. So really, truly delivering patient-centered care, which is at the heart of what we all try to do. I think all the early work that has been set up from all of our panelists have really been the drivers to enable this rapid upscale that you also mentioned, Rebecca, in terms of needing to upscale and to do that successfully for sustained implementation, because that's what we're aiming for, is a sustained service that is successful ongoing.
Yeah, absolutely. I mean, this is the driving force behind everything, and you've got to have the buy-in from clinicians to be able to take it forward. So it's really about skilling those clinicians up, and like Claire said, you're preparing people on both sides of the screen, so you really need to have those that are engaged with your assessment or that clinical observation, knowing what they need to do, but the clinician needs to be really prepared. So they need to have everything on the screen that they need, or anything to hand, so that they're not flapping about, and it's a smooth transition, just as it would be in face-to-face. And at the back of your mind, you're just trying to replicate what you would be doing if you were in a face-to-face environment, to give them that equitable care, and that they feel that they've had the same service as they would have done if they'd come to you in person.
Yeah. And just, I mean, my last question, just in regards to that, having that support, it's every trust or hospital clinic has their own personal barriers or facilitators that might help. So sounds like having some dedicated time and personnel to develop, making sure that you've got your own personal toolkits, that you've got your system, really does add to the success. Would panelists agree with that? Yeah. Okay.
Absolutely.
I'm mindful of time being 8:06, so I might hand back to Vincia and Michael to wrap up the session.
Thank you, Amy. Listening to everyone's talk today, it sounds like we've uncovered some hidden gold or pearl from different parts of the world. Amazing things that are being done, but I don't think many are aware of it. So hopefully this gives us a platform or an opportunity to learn from each other and go back and improve our care. So for those of you who are listening, if you want to contact our panelists, their emails are listed here. And remember, we will be sending you a link to our recording within the next 24 to 48 hours. So you can go back and watch it, or you can also share it with your colleagues who probably did not have the opportunity to listen today. As part of the Global Tracheostomy Collaborative, we invite each one of you to join our group. There are 3 ways of joining our collaborative. One is as a patient or family member. The second is as a healthcare provider. And the third is as a hospital. So please do go to globaltrach.org to learn more about this collaborative, so that we can share wonderful ideas, just like how we did today, to learn from each other and make sure that our patients are taken care of to the best ability possible. So with that, thank you, everyone, and we will be sending announcements about the next webinar soon. Take care.
Thank you all.
Thanks. Bye.
Thank you.